Good evening, sir.
وعليكم السلام.
وعليكم السلام
ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
السلام ورحمة الله.
Okay, guys, today, inshallah, we will start for resuscitation, the first chapter. It's very, very important in the exam. You are emergency physician, so you should think about the most important chapters in the curriculum. We are talking about emergency physician, so think about resuscitation, think about trauma, think about anything relative to emergency physician. Okay. So the blueprint we took last time, it will be 2 hours, then break, then 2 hours, then break. So 180 questions, 180 marks. So complex stable patient, 55 questions. Then resuscitation, 40 questions. Then injured patient. Pediatric, 25 questions. And procedures, 20 questions. So we will follow the curriculum. We have to do 31 chapters, okay? And regarding the procedure, we will do special session for procedure in the end. Complex challenging situation will be 10 questions. So it's not too much, 10 questions. So you have to study JMC guidelines and so on. Again, they will ask you about relevant basic sciences, relevant epidemiology, differential diagnosis, investigation, management of this condition. Anything with red color will be pediatric. Otherwise, it will be pediatric and other. So these are the chapters from resuscitation. So next time we will discuss allergy, after that cardiology, and so on. We will go through the curriculum. The end will be safeguarding psychosocial emergencies in children. So today we'll talk about resuscitation, clinical presentation and condition issues. So we will discuss acute airway obstruction. But today I will talk about airway, breathing, circulation, disability, and exposure as well. Anaphylaxis, anaphylactoid reaction, cardiorespiratory arrest, major trauma, respiratory failure, sepsis, shock, unconsciousness. So here they can give you any scenario with airway obstruction. Can you hear me, guys?
Yes, sir.
And
Yes, clear.
Loud and clear.
okay, because they said they can hear in the group. Okay. So here in the scenario, they will give you any presentation, for example, whatever 30 years of male patient presented with stridor. They will not say airway obstruction, but they will give you any clue that you will understand that he has airway obstruction. For example, he was eating, after that he has collapse, whatever, large tongue or whatever. So you will understand that he has acute airway obstruction. I want you, when you are studying, expect the question, how the examiner will ask you. They will not ask you regarding memorization. They will not ask you, give me cause of this. No, They will give you scenario, clinical scenario, and you will answer accordingly. Okay, so here also shocking, stridor, organ donation, bro, solid protocol. So acute airway obstruction, of course, it will be blockage in the airway, whatever partially or totally. Partially, the patient is still alive. Totally, I think he will go to arrest. So here, it will prevent air from reaching the lungs. So here, we will discuss ALS, ATLS, APLS, and the newborn resuscitation. So here, in adult ALS and ATLS, same but with trauma. APLS will be a child and newborn resuscitation. So first of all, I will discuss how to deal with emergency case in resuscitation room. So first of all, you go behind the head of the patient and check the airway. How to check the airway? You have to open the airway first. So you have two ways to open the airway. So head tilt chin left, head tilt chin left, or just rest if trauma. After that, you check the airway. If you find secretions, you will do suction. If you find any foreign body, you will remove by forceps. And if you find vomiting, you will do suction by rigid suction. So you have to be sure that the airway is clear. After that, you have to maintain the airway. So once you remove your hand, the airway will be closed. The mouth will be closed again. So you have to maintain the airway open. How to do oropharyngeal airway, both oropharyngeal airway or nasopharyngeal airway. After that, you apply source of oxygen. Source of oxygen here may be non-rebreathal mask, 15 liter, if the patient is spontaneously breathing. So if the respiratory rate normal, it means from 12 up to 20. If you find the respiratory rate less than 20, so the patient has bradypnea. So you have to use back valve mask. You have to use back valve mask in two cases, hypoventilation or respiratory rate less than 12, or oxygen saturation less than 94. After that, you will go to breathing. So breathing here, we are talking about chest. So you will expose the chest, connect all monitors. After that, inspect, palpate, percuss, auscultate. So inspection, palpation, percussion, auscultation. After that, you will ask about oxygen saturation and respiratory rate. After that, you will ask about trachea, central or deviated. You will ask about neck veins, normal or congested. If you understand that, you will pass ALS, APLS, ATLS, 3 stations in next exam, OSCE exam. Okay, so this very important, and if you understand, it will help you later and in your daily living. So after you finish breathing, if everything normal, we finish the airway is patent now. After that, breathing. After that, circulation. Circulation here, you have to ask about blood pressure, CRT, heart rate, and extremities cold or not, and so on. So after that, you can insert to IV access, extract blood for hematology, biochemistry, blood gases, blood culture, and toxicology screen in any resuscitation case. Hematology, biochemistry, blood gas, blood culture, and toxicology screen. You will add a special test in a special consideration. For example, the patient has chest pain, severe chest pain. So you will add cardiac enzyme. If the patient has anaphylaxis, you will add mast cell tryptase. If the patient has trauma, so you will add group and saving and cross match and so on. Okay. After that, if the patient has hypotension, you will give fluid. So fluid here, you will give 1 liter normal saline according to ATLS 10th edition. So you will give up to 1 liter. If ATLS, you will give also tranexamic acid. You will give O negative blood 2 units. You will give a cross match 4 units. Of course, if not responding, you have to escalate. You have to go to the next step. Okay. Also, for example, if the patient, you can add medicine according to special consideration. So if the patient has massive upper GI bleed and it's ALS case, so you will add also terlipressin esophageal bleeding. We will discuss that in details in its chapter. After you finish circulation, you will go to the disability. In disability, you will ask about blood sugar. You will ask about pupils, bilateral equireactive or not, and you will ask about GCS. You will, in pediatric, you will ask about AFBO. Instead of GCS, you will ask about AFBO score, alert or responding to verbal or pain or unresponding. So after you finish disability, you will go to E, exposure. Exposure means you will expose all the body. You will look at the patient from the end of the bed and ask about temperature and exposure. Okay, any rashes or any deformities or any trauma or anything. Okay, so we have talked about a brief idea about ATLS, ALS, ABLS, and so on. In ATLS, in C, you will add an inspection palpation of the abdomen. Like an inspection here, you will ask about obvious injuries, wounds, and palpation, you will ask about any tenderness guarding rigidity. Also, you will ask about any deformities in any limb, and so on. Okay, we will talk about tachycardia. So, as you know, the heart rate normal from 60 to 100. If more than 100, so we are talking about tachycardia. If less than 60, we are talking about bradycardia. So you have to follow the ABCD approach as we discussed. Okay. Here you have to check signs of instability. How to know this patient is stable or not? Okay. So the patient is tachy, okay, and he has shock, so it's unstable tachycardia. The patient has syncope, it's unstable tachycardia. Myocardial ischemia. How to know it's a myocardial ischemia? The patient has chest pain, so it's a myocardial ischemia. Or the patient has ECG of ischemia, so it's a myocardial ischemia. Number 4, severe heart failure. So if you auscultate the heart, listen to the heart, and you find SS3 gallop or 4 gallop, or you find basal crepitation, so the patient has severe heart failure. So in this case, you will go directly to synchronized DC shock. You can give first shock, if failed, second, if failed, third. After that, if failed, you will give amiodarone 300 milligram IV over 10 to 20 minutes. You can repeat synchronized DC shock. After that, if failed. Of course, you have to give the patient sedation or anesthesia if conscious. Okay. So what if the patient has QRS narrow, okay, or QRS broad? So if the QRS broad and regular, okay, and the QRS narrow and regular. So QRS wide here, you have to check irregular or regular. Okay, so irregular means atrial fibrillation, or maybe polymorphic VT. We will discuss all ECGs in cardiology, but I want you to, even if you are not familiar with ECG, just check QRS in the exam. If you find it's irregular, so we are talking about atrial fibrillation or polymorphic VT. If regular and wide, so we are talking about VT. After that, narrow, so we are talking about SVT if regular. If irregular, maybe atrial fibrillation as well. So here, you have to use treatment for atrial fibrillation if stable. So you will give beta blocker or calcium channel blocker. Here, if regular, you can use amiodarone, but this time it will be 10 to 60 minutes. Okay. Here, if regular, so for example, supraventricular tachycardia, so you can give adenosine. We are talking about new guidelines 2021. So it will be 6 milligram, 12 milligram, 18 milligram. Before it was 6 milligram, 12, 12. Now they changed to 18. Okay. So here, if irregular, it will be atrial fibrillation as well. So again, beta blocker or calcium channel blocker or whatever. Okay. If ineffective, the patient is stable. Stable, we are talking about shock, syncope, myocardial ischemia, and severe heart failure. So the patient is stable. He doesn't have any sign of instability, but he's not responding to medical treatment or not responding to pharmacological treatment. Pharmacological treatment is called pharmacological cardioversion. But if you will give shock, it's called electrical cardioversion. So you have electrical cardioversion and pharmacological cardioversion. If the patient is not responding to pharmacological cardioversion, so you can give synchronized DC shock up to 3 attempts again. And if the patient is conscious, you can give sedation or anesthesia. So here, this is the monitor, the defibrillator. Number 1, you will turn on. After that, so number 1, you will turn on. After that, analyze the charge. So here, if white complex, you can give synchronized. You have to put the button here on synchronized mode. And you can choose if white complex, like this one, so you can choose 120 up to 150. If narrow complex, you will choose the energy will be 70 up to 120. Okay, so narrow and wide. Narrow will be 70 to 120, and if wide will be 120 up to 150. If you find the atrial fibrillation, you can deal as wide complex tachycardia. If you find the atrial flutter, you can deal as narrow complex tachycardia. Okay, so you can give shock. Bradycardia, so we are talking about heart rate less than 60. You will follow ABCDA approach as we discussed in the start and check for signs of instability. If the patient has shock, syncope, or myocardial ischemia or heart failure, so here you have to give atropine. If the patient has bradyarrhythmia and is stable, it means he doesn't have shock, syncope, myocardial ischemia, or heart failure. So just observe. No need to do anything. So if they give you scenario for bradyarrhythmia and you don't find any of the 4 signs of instability, and they give you options to choose, just observation. But if they give you any signs of instability, so you will choose atropine. Atropine here, 500 microgram equal 0.5 milligram IV. So if not respond, you can give up to 3 milligram. If not responding, isoprenaline 5 microgram per minute, or adrenaline 2 to 10 microgram per minute, or alternative drugs. So alternative drugs here, sometimes it depends on the situation. For example, the patient is taking beta blocker, or they give you any clue in the scenario that the patient has overdose of beta blocker, or he has hypertension and he is taking, for example, labetalol or Enderal. So you will understand that it's a beta blocker overdose. You can give glucagon, but you have to start by the normal algorithm. Even you understand it's because of beta blocker, so you will use atropine if the patient is responding. So no need to go to the alternatives, but you have to go to the alternatives if not responding, and so on. Okay. So glucagon here, if beta blocker or calcium channel blocker, you have to consider. After that, if not responding, you have to use transcutaneous pacing. Transcutaneous pacing here as defibrillator. Sometimes the defibrillator and pacing in the same machine. So you will use pacer mode. You will turn on. After that, you have here milliampere current. Here's the current. You have here pulse per minute. So once you turn on the machine, you will find 70. It's a default. So you will choose 30 milliampere. It will be 0. You will increase up to 30 milliampere. Now you can see this spikes. This spikes, it's called basing rhythm. But how to understand it's successful or not? Should be H basing followed by QRST. So what do you think, guys? This one followed by QRST? This spike, first one?
Yes, sir.
Yes.
What about the second one?
No.
No.
Not big.
So between this spike and this spike, there is no QRST, right?
Yes.
But here, this spike and this spike, there is QRST between them, right?
Yes.
Yeah. So this
Yes.
one is successful, but this one it's not successful. And if you find all the monitor like that, it means not successful. So what is called this basing rhythm without electrical capture? Electrical capture, it means should be followed by QRST. What you will do, you will increase the milliampere 10, it will be 40, and check. Is it electrical capture, guys?
No, QRS still
No,
missing.
sir. No.
No.
The second one is no.
Okay, so the second one and the fourth one not followed by QRST. After that, you will increase to 50. Okay, so what about the electrical capture? Is there?
Still missing.
So you will
Same.
increase to 70. What about this one?
Yeah, capture.
Yeah, so
There
now,
is capture.
Capture.
yeah, so this one followed by QRST, this one followed by QRST, this one followed by QRST, and all. So now you have basing and you have electrical capture. So the next step, you will check mechanical capture. Mechanical capture, it means you will check blood pressure, you will check also pulse and GSS. Okay, so here also pediatric arrhythmia. So pediatric arrhythmia here, you have to check signs of circulation. Is the patient, you will follow ABCD approach as we said. Okay, airway, breathing, circulation, disability, and exposure. So if you find signs of circulation, okay, or no signs of circulation, if you don't find signs of circulation, it means the patient is at rest, and you have to follow ALS or ABLS, ABLS algorithm. So if the patient has signs of circulation but decompensated, what does it mean? He has signs of vital organ perfusion compromise, like reduced loss of consciousness. He's alive, but reduced loss of consciousness, tachypnea, bradypnea, or tachycardia, and the blood pressure less than 5th centile, CRT more than 2 seconds, weak or impalpable peripheral pulses. So here, the blood pressure according to the age, the accepted blood pressure according to the age. So 50 per 1 month, 70 1 year, 75 5 years, 80 10 years. So if you find this blood pressure in the scenario, you will understand it's normal according to the age. How to understand it quickly it's normal or not? CRT. If you find CRT less than 2 seconds, so it's normal. If you find CRT more than 2 seconds, so it's a shock, regardless the blood pressure. So here, if the patient has bradycardia, it depends on the age. If the patient less than 1 year, so the normal for 1 year, 80 per minute. Normal more than 1 year, 60 per minute. Okay, so infant 80 and child more than 1 year, 60. Okay, so if you find bradycardia less than 80 or less than 60 according to infant or child, what you will do, optimize oxygenation. It means you will give back valve mask, oxygen, 5 risk breaths, 1, 2, 3, 4, 5. After that, check. No bradycardia, so it's improving. If you see the same heart rate, so in this, at that point, and if the patient unconscious and the heart rate less than 60, despite oxygenation, you will start chest compression. Start chest compression and the patient is alive? Yes. So we are following their guidelines. No response to oxygenation, so you have to check if vagal stimulation possible. How to understand? Maybe bradycardia because of intubation. For example, you intubate the patient and you find the patient after intubation, he has bradycardia. So bradycardia here, you can treat by atropine. So this is the only case you can give atropine. If no vagal stimulation, so you have to do chest compression. Okay? We finished the bradycardia. We will go to tachycardia. So tachycardia, you will check if narrow complex or broad complex. If broad complex, you will give synchronized cardioversion. Okay. Of course, to give any sedation and the patient is conscious, you will give here, because it's pediatric, you will give ketamine intranasal. So they can give you questions like that. They can give you scenario and you will choose option for ketamine intranasal. Okay, IM or intranasal ketamine. Okay, so if tachycardia and narrow complex here, how to understand it's sinus tachycardia? Sinus tachycardia, no need for any intervention. SVT, you have to intervene with the patient. So if infant more than 220 per minute, or child more than 180, so it's supraventricular tachycardia. At that time, you can give synchronized cardioversion. The same, you have to give sedation, analgesia, and sedation. So IM or intranasal ketamine. Okay. Again, here regarding atropine, will be 20 microgram per kilogram. We are talking about pediatric. If the patient is stable for SVT, you can give adenosine. If the patient broad complex and stable, so you can give amiodarone 5 milligram per kilogram. So here, the synchronized cardioversion will be first shock 1 joule per kilogram, second shock 2 joule per kilogram, consider up to 4 joule per kilogram, and also consider amiodarone before the third shock. So here we are talking about the patient is alive, guys, not arrest. Okay, we will discuss arrest in topic 3. Okay, so here when the ambulance crew, they will call you and they will tell you you have patient will arrive after 2 minutes. You have to prepare yourself. So you will introduce yourself to your team and recognize your team. And after that, explain the case you will receive to your team. For example, we are expecting one patient pregnant. So we have to prepare anything related to pregnancy. Task, you have nurse for airway and the nurse for circulation. So you have to assign roles. After that, you will ask the nurse A to check airway to roll the oxygen, mount suction. The nurse for circulation, check defibrillator, pacing, medication, resuscitation trolley, and so on. Call team early. For example, if ALS or ALS, you will call for resuscitation team early. If the case is trauma team, so you will call for trauma team. Wash your hand and wear PPE. When the patient arrived, you will take brief history from the ambulance. So here, airway, breathing, circulation, disability, exposure, as we discussed. Sometimes you will find the patient difficult airway. You cannot manage the airway. We said in airway, you will open the airway, you will use suction, you will use oropharyngeal or nasopharyngeal, you will use non-rebreather mask. After that, if not spontaneously breathing, you will use back valve mask. So if the patient is not responding, the oxygen saturation is less than 94 after all these interventions. So you have to go for difficult airway prolonging. So plan A, plan B, plan C, plan D. Okay. So plan A here, face mask ventilation means back valve mask and tracheal intubation. So you will intubate the patient first attempt. If the patient first attempt failed, you will go to second attempt. If second attempt failed, you will go to third attempt. Okay. So if 3 attempts fail, you can declare failed intubation. After that, you can go to plan B. So plan A, it's 3 attempts for intubation. So back valve mask and intubation. Plan B, maintain oxygenation. So supraglottic airway device. If failed, you can go for face mask ventilation. If failed, you can go for emergency front of neck access, means surgical airway. Surgical airway, it means cricothyroidotomy or needle, whatever needle or surgery. In trauma, you will add manual inline stabilization. By this way, you will be behind the patient and do manual inline stabilization. So if you find this option in the scenario, you can choose. Again, airway maneuver. So chin lift, head tilt, chin lift. If the patient has trauma, it will be only just thrust. So this one, just thrust. This one, head tilt, chin lift. This one, just thrust if there is trauma. If the patient is not responding, you will do look, listen, and feel. After that, open the airway. If you find any secretion suction, any vomiting suction by rigid oropharyngeal airway, to keep the airway open. So this one, oropharyngeal, from midpoint of incisor up to angle of mandible. This is how to insert. So upside, downside, towards the hard palate, and then until the middle. After that, rotate 180 degrees. Here, nasopharyngeal airway from the nose up to the tragus of the ear. After that, non-rebreather mask, if the patient is conscious or even unconscious, but maintaining breathing, spontaneous breathing. If not, or respiratory rate less than 12, so you will use back valve mask. If the patient is not responding to all intervention, you have to go for intubation. So what is the plan A, guys?
Face mask ventilation and intubation.
What is the plan B?
Supraglottic airway devices in maintaining oxygenation.
What plan C?
Face mask ventilation.
Face mask ventilation.
Plan D?
Access to anterior neck surgical airway, emergency surgical airway.
Ecothyroidotomy.
Okay. So how to check success? When you are using back valve mask, you have to check chest rise. If you find chest rise, it's successful. Okay. So even intubation, you will connect it to back valve mask and check chest rise. If the patient has trauma, after you do manual inline stabilization, after airway is patent, so you will put cervical collar. Okay. After intubation, you have to check the tube is in or not. Sometimes, if you find the tube oxygen saturation after intubation 98 or more than 94, so it's in. If you find in tidal CO2 normal, so it's in. But if you find the oxygen saturation, for example, 80 or 70 and not decreasing, So it's in the right main bronchus. Okay. So this one in the right main bronchus, this one in the left main bronchus. So you have to withdraw the tube up above the carina. So this one where in the right or in the left?
Right.
In the right. So yeah, the tube now occluding the left main bronchus. That's why the left main bronchus, the left lung collapse, white color, because it's a collapse. If the air go inside the lung, the air with black color. Okay. Okay. So we will go directly to acute airway obstruction. So as we discussed, okay. So here, how to assess the airway? The patient already is still alive and waiting for any procedure. So you have to assess the airway. If the patient has emergency, it's difficult to assess his airway. You don't have time to assess his airway. It's called emergency intubation or emergency airway. Okay, but here Malambati score or Cormack and Lehane score. These scores, if the patient, you will do elective intubation. For example, you will intubate the patient after 1 hour, 2 hours, 3 hours, and so on, or maybe tomorrow. So you have to assess his airway. But if the patient has anaphylaxis now and you cannot control his airway, you have to intubate now. You don't have time to assess his airway. Okay. So Malambati class 1 here. If you see the tip of the uvula, so it's case 1. Class 2, you will see the base only. Okay. So here, class 3, class 4, Cormack and Lehane. So you can see the vocal cords, grade 2, partial visualization of the vocal cord. This grade 3 and this grade 4. Okay. They can give you any picture or any image in the exam and ask you regarding the class of Malambati or regarding the grades of Cormack and Lehane score. So what about image C? Which grade, guys?
3.
Okay. Which is the most difficult?
4.
4.
3. Okay. So here you have difficulty airway to only 4 drawers for plan A, plan B, C, and D. So what is A?
Vocal cord.
Vocal cord.
B?
Trachea.
Trachea.
Epiglottis.
D?
Piriform fossa.
Piriform fossa.
Okay.
From fossa.
Yeah. So here the airway is considered threatened when GCS is less than 8. So causes of airway obstruction may be blood, vomitus, foreign body in the airway, direct trauma to face or throat, epiglottis, laryngospasm, bronchospasm, pharyngeal swelling. So if you find any one of them in the exam, you can choose. Okay. Pharyngeal swelling, infection, edema, bronchial secretions, blocked tracheostomy, burn, inhalational injury, and so on. What is the problem in burn? Inhalational injury. So early evaluation of the airway is crucial part of the management of burn patient. Here, airway obstruction can occur rapidly because of direct injury or inhalational injury. If there is any associated history of trauma, so the airway should be assessed and managed with cervical spine, as we said. Any trauma, cervical spine. Signs of airway obstruction can be subtle at the time of presentation, but maybe after 5 minutes or 10 minutes, the patient will have edema and it will obstruct the airway. Children with thermal burns at higher risk of airway obstruction than adults because of relatively smaller airway size. The children, they have smaller airway size. That's why they are at high risk. Risk factor for airway obstruction in burn patient. Why? If the patient has burn, he has high risk of airway obstruction because of inhalational injury. If you find in the scenario soot in the mouth or nostrils, so it's inhalational injury. If you find singed nasal hair, burn to head, face, neck, so it's inhalational injury. Burn inside the mouth, large burn areas and increasing burn depths, associated trauma, or you find carboxyhemoglobin level more than 10%, this is suggestive of inhalational injury. So here in burn, you have to treat with definitive airway management. Definitive airway, it means endotracheal tube, okay? Indication for early intubation in general. So signs of airway obstruction, if you find hoarseness, stridor, accessory respiratory muscle use, external retraction. Sometimes in the exam, they will not ask you indication of early intubation. No, they can give you, for example, scenario, the patient has hoarseness, stridor, and they will ask you for the next step or something like that. So you will choose definitive airway, early intubation, okay? This is how to expect the question. Extent of the burn, so total body surface area more than 40% or 50%. So if they give you scenario of burn and they said body surface area 50%, and the next step we can talk about early intubation. Extensive deep facial burn, burn inside the mouth, significant edema or risk for edema, difficult swallowing, signs of respiratory compromise, the patient unable to clear secretion, respiratory fatigue, poor oxygenation or ventilation. Decrease the level of consciousness where airway protective reflexes are impaired. So if the patient has head trauma, for example, and he cannot protect his airway, so early intubation. Anticipated patient transfer of large burn. So any transfer, you have to go to early intubation. Circumferential burn of the neck can lead to swelling of tissue around the airway. So here you have to go to early intubation. So patient with burn should usually be administered high flow oxygen reservoir. Intubation is necessary. It is vital to use appropriately sized endotracheal tube. Tubes that is too small will make ventilation, clearing of secretion, and the bronchoscopy difficult or impossible. So you have to choose the correct ET tube. ATLS guidelines recommend ET tube at least 7.5 millimeter internal diameter or larger in adults and 4.5 in children. You have to be familiar with that. 7.5 adult, 4.5 children. And those patients that have intubated, 100% oxygen should be continued until carboxyhemoglobin level for less than 5. So here, carboxyhemoglobin, as we said before, how much? If more than 10%, it means airway obstruction. Lung protective ventilation should be used with low tidal volume. Any lung protective strategy, you have to start by tidal volume very low. So if you will ventilate the patient connect to ventilator machine, so you have to start tidal volume 6 to 8 or 4 to 8, no worries. And the peak inspiratory pressure less than 30. So here, as we discussed, jaw thrust or chin lift maneuver as initial intervention to open the airway in trauma patient. Movement of the head and neck should be avoided in trauma patient with suspected cervical injury. If the patient is unconscious and no gag reflex, the placement of oropharyngeal airway can be helpful temporarily. So any patient, you will put oropharyngeal airway, it means he needs the intubation. Okay. no gag reflex, think about intubation. Okay. Chin lift maneuver is performed by placing one hand under the mandible and then gently lifting it upward to bring the chin anterior. So what do you think regarding this patient, guys? What is the GCS for this patient?
Less than 8.
Maybe drop.
Okay, so once you see this image in the exam, you have to expect airway obstruction. I don't care about anything here.
Airway obstruction.
Yeah, airway, breathing, circulation, disability, exposure. So the first killer is the airway. Okay. Second killer, breathing. Third killer, circulation. Fourth killer, disability. And the fifth killer, exposure. Okay. So here you have to think about airway. I can see the mouth is closed, or I cannot see the mouth. So maybe the nose also closed with bleeding. So here my concern, airway. So I will open the airway, I will clear by suction, I will put oropharyngeal airway or nasopharyngeal airway. After that, nasopharyngeal airway, it's contraindicated in trauma. Don't use nasopharyngeal airway in trauma because maybe there is fracture between the nose and the brain. So here, after that, you can intubate the patient. So regarding trauma, we finished intubation and burn. So here in trauma, we want to intubate if the patient has apnea, GCS less than 9, sustained seizure activity, unstable mid-phase trauma, airway injuries, large flail segment. So we are talking about breathing. He has flail chest fracture in the chest, high aspiration risk, inability to otherwise maintain airway or oxygenation. So we talk about Lemon assessment. Lemon assessment here to predict difficulty intubation. So the patient is stable enough to do Lemon assessment. So here Lemon means look externally, evaluate 332 rule, M Malambati, we discussed the Malambati, O obstruction, and N neck mobility. So if you find any of them, it means it's a difficult airway. Here, you have to be familiar with cricothyroid membrane. Okay, so thyroid cartilage and cricoid cartilage, between them cricothyroid membrane. Also, you have to be familiar with cricothyrotomy. Okay, you have to be familiar with indications, contraindications, and complications. You have to study. So when you listen to this video, you can read this slide, and you have to be familiar with the equipment. Okay, maybe they will ask you in the exam what indication, what contraindication, complication, you can choose. And also equipment, what equipment needed. So you have to be familiar. So if you find any of them, you can choose. You can use ultrasound guided. Here also for a needle. So you can insert the needle and you can connect it to syringe and back valve mask. And you can use three-way tab. So this three-way you can use by your thumb to control the ventilation by thumb. Here, surgical cricothyrotomy. So you have to be familiar with the steps, okay, and inner cannula, trocar, and the outer tube. So you will do opening in the membrane. After that, by forceps, you can widen. After that, you can insert according to the steps. Okay, so needle thyroidotomy. So you have to be familiar with the steps. You can read this slide. Contraindication, complication, you have to be familiar. They can ask you directly in the exam. Also surgical thyroidotomy. As we said, needle or surgical, we are talking about plan. Which plan, guys, in difficult airway?
Plan 4.
Plan D. So you have to be familiar with the steps. Okay, presentation number 2, anaphylaxis, anaphylactoid reaction. So you have to be familiar with EpiPen. It's an adrenaline auto-injector used in the treatment of anaphylaxis. Sometimes also, when the patient is injecting himself, he will inject in his thumb. Okay, so you have to be familiar with complication, and also it will cause ischemia to his finger. So you have to treat with vasodilators, drops, or ointment. So here, auto-injectors are often given to patients at risk of anaphylaxis for their own use. Healthcare professional should be familiar with the use of the most commonly available auto-injector device. If adrenaline auto-injector is the only available adrenaline preparation when treating anaphylaxis, healthcare professionals should use it. So if you find this auto-injector with the patient and you don't have adrenaline, you can use. EpiPen auto-injector contain 0.3 milligram. As you know, the doses 0.5 ml or 0.5 milligram more than 12 years. Okay, so child over 12 or adult, you can use 500 microgram or 0.5 ml or 0.5 milligram, same. But 6 to 12 years, you can use 0.3 ml or 0.3 milligram, same, or 300 microgram, same. Child under 6 years, so 150 microgram. But here, auto-injector, the dose is 0.3 milligram, okay? There is no 0.5. So here, the new guidelines for anaphylaxis, they removed chlorpheniramine and they removed hydrocortisone. It's not in the algorithm anymore. So first of all, you will use ABCDE approach. How to diagnose anaphylaxis? So sudden onset of airway and or breathing and or circulation problem. And usually skin changes. So here, if you find any of them and it was sudden, so you are talking about anaphylaxis. What you will do, you will inject adrenaline IM in the anterolateral aspect of the middle third of the thigh. And you can repeat after 5 minutes. Okay. Also, so number 2, adrenaline. So number 1, you will diagnose. Number 2, adrenaline according to the age. And number 3, IV fluid. So 500 to 1000 ml in adults. In children, 10 ml per kilogram. So here they removed chlorpheniramine and hydrocortisone. It's not used anymore. If the patient is not responding, so it's called refractory anaphylaxis. Okay, so you can repeat adrenaline every 5 minutes. Okay, and also you can continue oxygen, fluids, and everything as required. Okay. So regarding adrenaline, if given IV, it's by expert. So it will be over per hour. It will be per hour. So in both adults and children, start at 0.5 up to 1 ml per kilogram per hour, and the titrate according to clinical response. Okay. Cardiorespiratory arrest. So if the patient not responding, and what you will do after not responding, guys? What is the first action?
Shout for him.
Call for help.
Call for
Or for help.
Look, listen, and feel. Look, listen, and feel. Look, listen, and feel. Maybe he's alive, right? You will call for help, and the patient, maybe the patient is, once you talk to him or once you shake his shoulder, he will talk to you. You will call for help, and all the hospital will attend to you, and the patient is alive. So you have to confirm arrest, right? Okay. So chain of survival. Activation of emergency response, high quality CPR, defibrillation, advanced resuscitation, post-cardiac arrest care, and recovery. Here you have to be familiar with adult ALS and pediatric ALS. So if the patient unresponsive and not breathing, so you confirm already he is arrest. After that, call resuscitation team. After you confirm arrest, so you will start CPR 30-2, attach defibrillator monitor, assess the rhythm. You have to rhythm shockable. So you find on the monitor VF or pulseless VT, so you will give shock. After that, CPR for 2 minutes. If you find the rhythm, it's a non-shockable, so BEA or asystole, so you will not give shock. You will do immediately resume CPR. So here you have to give oxygen, waveform capnography, continuous compression if advanced airway. If the patient intubated, you will not do 30-2. No, it will be chest compression, it will be continuously. Okay, minimize interruption, intravenous or intraosseous access. I want to give intravenous access, guys, after how many attempts for IV access?
2 times.
2 times or 3 times?
3 times.
2
3
times.
times.
So if failed IV access, you will give IO access. Give adrenaline every 3 to 5 minutes. Give amiodarone after 3 shocks. Identify and treat reversible causes. So reversible causes, hypoxia, you will give oxygen. Hypovolemia, you give fluid. Hyperkalemia, you will correct. We will discuss now. Hyperthermia, you will correct. Thrombosis, you will give thrombolytic drugs, whatever it's a coronary or pulmonary. Tension pneumothorax, you will do needle thoracocentesis followed by chest tube. Tamponade, you can do thoracotomy, or you can do ultrasound guided pericardiocentesis. Consider ultrasound imaging to identify reversible cause. Also consider coronary angiography, percutaneous coronary intervention, mechanical chest compression, and extracorporeal CPR. So what if the patient has ROSC? Now the patient has return of spontaneous circulation. So again, you will assess the patient ABCDE approach. Your oxygen saturation should be 94 and more. 12 leads ECG, identify and treat cause. Targeted temperature management, you can say 32 to 34. In pediatric, the same. But the difference here, don't forget 5 initial breaths. Then you will do a compression ventilation ratio 15:2. The same, everything is the same, but different in the doses. So here, the first shock will be 4 joule per kilogram. Here in adult, you can give the shock, it will be 150 or 200 by physic. But in pediatric, you can give
1 joule in first shock.
1 shock 4 joule per kilogram. 4 joule per kilogram. Okay. And regarding adrenaline, it will be 10 microgram per kilogram. Okay. Amiodarone, it will be 5 milligram per kilogram after 3rd and 5th. In adults, we said amiodarone after the 3 shocks, and it will be 300 milligram. And after 5th shock, it will be 150 milligram.
150.
Yeah. But in pediatric, it will be 5 milligram after 3rd and 5th, same dose. Okay. If non-shockable, it will be the same. It will be adrenaline only and chest compression. So it will be 10 microgram per kilogram. Regarding newborn, the patient just born now and he is not breathing or heart rate less than 60. If the patient newborn and heart rate less than 60, so you have to follow this algorithm. First of all, you will do team briefing and equipment check. After that, when you receive the baby, delay cord clamping for at least 1 minute. Start the clock, no time, dry and wrap the baby, stimulate, and keep warm. Assess, check for color, tone, breathing, heart rate. So if the patient is airway not patent, you will open the airway and clear. After that, breathing. If you find the patient gasping or not breathing, so you will give 5 inflation breaths. So each inflation will be 3 seconds. Each inflation, 3 seconds by back valve mask. 1, 2, 3. It's 1. 1, 2, 3, 2. 1, 2, 3, 3, and so on. So 5 inflation breath. After that, reassess. If the patient is still no breathing, you will give another 5 inflation breaths, but this time it will be 2-person technique. It will be 2-person technique. Okay, so 1 person for back valve mask and 1 person for inflation. After that, if the chest is moving and the heart rate is not there, no increase in heart rate, not increasing than 60, so you will give 30 ventilation breaths, 30 ventilation breaths. Each ventilation within 1 second. So what is the difference between inflation and ventilation? Inflation, 3 seconds. Ventilation, 1 second. Okay. So ventilation here for the heart rate, but inflation for the chest moving. Okay. So you will give 30 ventilation for 30 seconds. After 30 seconds, you will check again. If you feel the heart rate same, you will give chest compression. 3, 2, 1. Okay. For 30 seconds. If it's still the same, heart rate the same or not detectable, so you will do chest compression, but this time you will give adrenaline as well. So you will insert the vascular access in the umbilical access and give drugs. Drugs here, it will be adrenaline. How many microgram, guys, per kilogram?
10 microgram.
10 micrograms.
The new guidelines, 20 microgram. 20 microgram. You can review, guys, regarding the adrenaline in the website Resuscitation UK guidelines. It's very important. Maybe they will ask you. Okay. After that, consider 4H and 4T. 4H and 4Ts in newborn The most important here, pneumothorax, hypovolemia, congenital abnormality. So they can ask you direct question in the exam. What is the most likely cause in this newborn? So you can choose any one of them if you find. If you find pneumothorax, choose. Hypovolemia, choose. Congenital abnormality, choose. This is how to study. This is how to expect the question, how to pass. Okay? So cardiorespiratory arrest, what are the causes? Hypoxia. So hypoxia, you will give oxygen and also you will treat the underlying cause. Hypothermia. So the most important in hypothermia, you will use low reading thermometer. How to understand it's 32 or 28. So not all thermometers check low reading temperature. So you have to use low reading thermometer and also check for presence of vital signs for up to 1 minute. In any arrest, you will check for the pulse for 10 seconds, but here in hypothermia for up to 1 minute. Hypothermic patient with risk factors less than 30, ventricular arrhythmia, systolic blood pressure less than 90. Those in cardiac arrest should ideally be directly transferred to extracorporeal life support for rewarming. So in any patient hypothermia, you will use active and passive rewarming. We will discuss that. So chest compression and ventilation should be different to CPR in normothermic patient. Consider use of mechanical chest compression device if prolonged CPR. So here, the difference between hypothermia and the other causes of cardiac arrest, you will use CPR maybe 90 minutes, maybe more. So it will be prolonged. So that's why you have to use mechanical chest compression. If ventricular fibrillation persists after 3 shocks, you will delay further attempt until temperature more than 30. So it can be an option in the question in the exam. Withhold adrenaline if temperature less than 30. It can be an option in the exam. Increase administration intervals for adrenaline to 6 to 10. We talk in general arrest, it will be 3 to 5 minutes, but here you will increase the interval, it will be 6 to 10 minutes. So it can be an option in the exam, okay? If the core temperature 30 to 34. So you will withhold the adrenaline until temperature 30. But once it will be 30 to 34, you will increase the interval. So here, the treatment, passive external rewarming, like blankets, active external, and active internal, extracorporeal. You have to be familiar with the types because they can give you option in the exam. For example, they can ask you which of the following is active external rewarming. So you have to choose. So if you find any one of them, you can choose. Cardiac arrest treatment due to sepsis. So sepsis here in general, you have to follow 6 sepsis. It means 3 in and 3 out. 3 in means you will give oxygen, give fluid, and give antibiotic. 3 out, it means you will take blood culture, blood gases, and urine output. So here you have to give fluid up to 3 liters in 3 hours. So intubate the trachea if able to do safely. IV fluid resuscitation, 500 ml initial bolus up to 3 liters. So you will give fluid here as fluid challenge. Any patient with shock, you will start by 500 ml bolus. Not responding, you will give another 500. Not responding, after 15 minutes, you will give another 500, and so on. So up to 3 liters. Control the source of sepsis and give antibiotic early. Hyperkalemia in arrest. So consider hyperkalemia or hypokalemia in all patients with arrhythmia or cardiac arrest. Check for hyperkalemia using point of care testing if available. ECG may be the most readily available diagnostic tool. So what do you think regarding this ECG, guys?
Hypokalemia.
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 Okay, so this ECG is hypokalemia, long QT interval. So long QT, it means the distance between, for example, here, for lead 1 from Q on the end of T wave. Can you see? It's very long. 1, 2, 3. It's almost normal, like two big square. Okay, but here it's more than 3 squares. So it's a very long. So it's a hypokalemia. What about this ECG? What do you think?
Hyperkalemia.
Yeah.
Hyperkalemia.
Yeah, big T wave.
Evaluations.
And T wave.
Yeah, and the white QRS. Okay, and the absent B wave. We will discuss this in ECGs and cardiology, inshallah. So here in treatment of hyper or hypokalemia, we will start by hypokalemia first. So the normal blood potassium 3.6 up to 5.2. So we are talking about if less than 2.5, sorry, if less than 3.5, it means it's hypokalemia. If more than 5.2, it's a hyperkalemia. But when to give management, you have indications. So hypokalemia, potassium level less than 2.5 millimole per liter, or ECG changes. Okay. So this one, potassium chloride, 10%, 10 ml. Okay. If the patient in cardiac arrest, if the patient has arrhythmia, so it's called peri-arrest, means at any time the patient will arrest. If the patient sinus rhythm and stable patient, okay. So regarding this ECG, guys, this one, it's a peri-arrest or sinus rhythm?
Sinus rhythm.
Sinus rhythm. Sinus rhythm, sir.
And this one, peri-arrest or sinus rhythm?
Sinus rhythm.
Sinus rhythm.
Okay, so arrhythmia, like for example, the patient has atrial fibrillation, VT, or any arrhythmia. So in this time, it will be different in the time only. So in all cases of hypokalemia, you will give potassium chloride. Okay, as we said, 10%, 10 ml potassium chloride. It will be in arrest 5 minutes bolus. In peri-arrest 30 minutes. It will be central access. If the patient is stable and sinus rhythm, so 60 minutes. So you will give 40 millimole per liter potassium chloride in 1,000 normal saline over 4 hours. Okay, what about hyperkalemia? So when to manage? If the potassium level more than 6.5 and the ECG changes. Okay, so whatever cardiac arrest or peri-arrest or sinus rhythm, you will give calcium chloride 10%, 10 ml, 10 minutes, 10, 10, 10. Okay, so here 1 gram. So if you find the option in the exam, 10% calcium chloride, same 1 gram calcium chloride. Okay, so you have to be familiar with this formulation. So here the normokalemia. Sometimes it's 3.5 up to 5. It depends on the laboratory. Sometimes up to 5.1 or 5.2. It's not a big issue. Moderate hyperkalemia, less than 8. Severe, more than 8. So here, what else you can give rather than calcium chloride? So you can give insulin and dextrose. Short-acting insulin, 10 units, and dextrose, 25 gram glucose. So if they said what other option you can choose insulin dextrose in the exam. What other option? You can choose sodium bicarbonate, okay, by rapid injection. What other option? Dialysis, if not responding. For refractory hyperkalemia. Refractory means not responding. Also, consider mechanical chest compression if prolonged. Thrombosis in cardiac arrest, whatever pulmonary embolism or myocardial infarction, so you have to expect the normal ATCO2 reading 4.5 up to 6 kilopascal or 35 up to 45 millimercury. It depends on the laboratory. So here, if you find low ATCO2 reading less than 1.7 kPa or less than 13 millimercury in CPR, this supports the diagnosis of pulmonary embolism. Consider emergency cardiography. Administer thrombolytic drugs. So you can use thrombolytic drugs or surgical embolectomy or percutaneous mechanical thrombectomy for cardiac arrest when pulmonary embolism is the known cause of cardiac arrest. So it can be an option in the exam. Cardiac tamponade in arrest. So you can decompress the pericardium immediately. You can use BOCUS, point of care echocardiography. It's called BOCUS. So ultrasound. Perform resuscitative thoracotomy or ultrasound guided pericardiocentesis. So it can be an option in the exam. When you are studying, guys, put options in your mind. If the examiner give you scenario, the patient has cardiorespiratory arrest, and he give you, for example, image of cardiac tamponade, and he ask you for the management, and he give you this option. So this is how to prepare yourself to the exam. Tension pneumothorax. Give you scenario for cardiorespiratory arrest and tension pneumothorax. How to understand? Sometimes he's not direct with you. He will tell you cardiorespiratory arrest and the patient, he has hyperresonance in the right side. So what you will do? So here you will do the compression in the right side immediately by open thoracostomy when tension pneumothorax suspected. Okay, needle chest decompression, rapid treatment, specific needle, longer, non-kinking. Any attempt at needle decompression under CPR should be followed by open thoracostomy or chest tube. Chest decompression effectively treat tension pneumothorax. So what is that, guys?
Cardiac tamponade.
Okay, so this is the heart, okay, left ventricle and right ventricle, and this effusion around the heart, this fluid, blood, and this blood around the heart, and this is the membrane around the heart. So between the membrane and the heart, it's peripheral effusion or tamponade. And this one also, so this is the heart, and this fluid between the heart and the membrane. In cardiac arrest, and the patient is pregnant, so you can do manual displacement of the uterus to the left side because it will relieve the pressure on the inferior vena cava, or you can use Cardiff wedge. Okay. So here in pregnancy, what are the modifications? Because it can be options in the exam. So call for expert help early, start basic life support according to standard guidelines. So you will follow the same algorithm of arrest and use the standard hand position or chest compression on the lower half. Here it will be on the lower half of sternum if feasible. If the patient in the scenario, they tell you, for example, it's 35 weeks pregnant. It means it's more than 20 weeks. So here you can do manually displace the uterus, okay, left lateral tilt, and also you can do early emergency hysterectomy. Early emergency hysterectomy, okay? If over 20 weeks pregnant, so here also you can place defibrillator pads in the standard position. Consider early intubation, and the intubation here by a small tube, because most pregnant, they have like edema, okay? So you can use tracheal intubation with a small tube, small size tube. What if the patient has trauma and cardiac arrest? So you have to expect hypovolemic shock, maybe obstructive shock, like tension pneumothorax or cardiac tamponade, maybe neurogenic shock, okay? So here you have to do resuscitation. You will control hemorrhage with external pressure, hemostatic gauze, tourniquets, and the pelvic binder. It depends on the case. For example, if he has pelvic fracture, so you will use pelvic binder. If the patient has amputation of both lower limbs, so you will do hemostatic gauze and the tourniquet, and so on. Immediate resuscitative thoracotomy. So this is a definitive treatment. If you find this option in the exam, you can choose immediate resuscitative thoracotomy. Okay, anterolateral thoracotomy in traumatic arrest. You have to be familiar with the steps. Okay. So this hemiclamp shell and bilateral hemiclamp shell. Okay. So here the patient has a stab wound in the heart. So now you can access the heart. You can do stitch and you can do CPR, but here direct compression for the heart. Okay. Cardiorespiratory arrest in pediatric. So the ratio of chest compression, as we said, 15:2 if a child. If newborn, we said 3:1. So here the same 100:120. Oropharyngeal airway is best used to protect the airway in unconscious child. Risk of vomiting and aspiration when used in awake patient. So if the patient is awake, don't use oropharyngeal airway. You can use nasopharyngeal airway. Asystole is the commonest arrest rhythm in children. So any child, you can expect asystole, non-shockable rhythm in arrest. And also the most likely cause is hypoxia or hypovolemia. So hypoxia and hypovolemia, but the most common hypoxia. Number 4, presentation number 4, major trauma. So as we said, major trauma, we are talking about maxillofacial, head injury, and the chest injury, abdomen, back, and major burn. So maxillofacial here, we are talking about upper face and lower face. Upper face, mid face, and the lower face, it means we are talking about mandible, okay? So the most important in the exam, the eye fracture, eye orbit fracture, and also the zygomatic maxillary complex fracture. So the inferior orbit, and also you have another fracture, the complex, zygomatic maxillary complex fracture. So it's 4 points. We will talk about that now. And also zygomatic arch fracture and mandibular fracture. So X-ray views, you have occipitomental 15 and 30 views. So this we are using in the zygomatic-maxillary complex fracture. Submento-vertical view, so we are talking about zygomatic arch. Orthopantomogram, we are talking about mandibular fracture and the temporomandibular joint dislocation. So if they give you image for a mandibular fracture, maybe they will ask you about the view. So you have to be familiar with that. Zygomatic arch, so submento-vertical view, and so on. So here, what is the diagnosis, guys?
Occipital view.
The diagnosis.
Fracture on the right side of the maxilla.
Maxillary fracture. Maxillary fracture.
So this view you can see it's occipitomental 15. So this view for what?
Midfacial.
Midfacial, okay. So it can be for orbit fracture or zygomatic-maxillary complex fracture, okay. This one, can you see? What's a fracture?
Zygomatic
arch.
Zygomatic arch fracture
Left side.
Okay.
onto the left side.
Yeah. So what is the view? Submento-vertical view. Okay.
Submento-vertical.
And this is view 30. So can you see the difference between 30 and 15? This one 15. It means the patient is looking forward with degree of
more extended.
Yeah. This one, it's a 30. Okay. What is the diagnosis here? Can you see the maxilla?
Zygomatic complex fracture.
Can you see the maxilla?
Yes.
Maxillary fracture on the right side.
So the right side here, I cannot see the maxilla completely, right? The triangle
Yes.
is it's obscured.
It's completely shattered.
Yeah.
This is
So
an oblique.
this one normal. This one
Yeah.
normal. Can you see the line up and the line down? Normal. But here it's a deformity here.
This is orbital
Yes.
floor fracture.
Orbital
Yeah.
fracture.
So it's
Superior
a
orbital wall fracture.
teardrop sign.
Teardrop sign. Yeah.
Drop sign. Okay. So that's why the fluid from the orbital here coming down. That's why you can see opacity here. Should be black, like this one. Okay. So if you find the orbit very thick like that, it means it's a fracture. What's the abnormality here?
It's
eyebrow
black
fracture.
It is
eyebrow
on the-
fracture sign.
Black eyebrow sign
Black eyebrow sign.
here.
Yes.
So this black color, it's not here. So this one normal, this one abnormal. So it is the same. It means orbital fracture. So this one orbital fracture, teardrop sign, and this one orbital fracture. Okay. It means the eyeball go down. That's why you can see the black color, because the eye go down. Okay. This fracture, it's a 4 component. That's why it's called zygomatic complex fracture. Okay. So this one, this one, this one, this one. Okay. So it's in the right or left?
Right.
Right side. It is on the right side.
Yeah. How to understand? Compare the inferior orbit. This one normal or this one?
It is on
The
the left
left
side.
is
It is
normal.
normal. On
Left
is
right side,
normal.
it is abnormal.
If you find the sick, this one thicker than this one. So this one fracture here. right?
Yes.
Yes.
And can you see the maxilla? It's very, very big here. It's good. And this one obscure. Because the fluid coming from the eye to the maxilla. Okay. And can you see the fissure here? It's normal. This fissure normal, but this fissure widened, right?
Yes.
Yes.
Okay. And this fracture here. Can you see?
Yeah, mild fracture on the zygomatic bone.
Here normal.
Yeah. Yes.
Okay. Clear?
Yes.
Yeah. Okay. So what is the view here?
Submental vertical.
Submental vertical view.
And what is the diagnosis?
Submental.
On the left
Left zygomatic arch fracture.
left zygomatic arch fracture.
Zygomatic arch fracture.
Okay. What is the diagnosis here?
Mandibular fracture.
Mandibular fracture.
Body of mandible.
Okay. So what is the view?
Orthoventogram.
Okay. So here in mandibular fracture, you have to be familiar with Manchester rule. Okay. So you have 5 points. 5 points. It's very important. If you find any of them in the option in the exam, you can choose. When to do X-ray for mandible. Okay. Any patient with head injury, you will do mandibular X-ray? No. 5 points only. If you ask the patient to close his mouth and you can see malocclusion, it's not occluding properly. If you find trismus, he cannot open his mouth. If he has pain when he closes his mouth. If you find by inspection broken teeth. If you find by palpation step deformity. So any of them, you will do X-ray for mandible. Clear, guys? What is the nerve injury?
Mental nerve.
Okay, so you have here mental nerve, and you have here what is the nerve here, guys?
Infraorbital.
Inferior orbital nerve.
Infraorbital nerve.
Infraorbital.
nerve.
Excellent. Infraorbital. It means under the orbit, okay, or below the orbit. So you have two nerves here in this maxillofacial injury. Infraorbital. It's related to the eye, and also mental, it's related to the mandible. Okay. This one, it's a dislocation. Can you see the shadow? This shadow? Because the mandible should be here. Okay. So temporomandibular joint dislocation. And this one, you have to be familiar with low forte fractures. Okay. So you have to maybe they will give you image in the exam and you will ask you which class of low forte fracture. Okay. So this one in the maxilla, this one involve the nose, this one involve the eyes, orbital. Okay. Okay.
Daniel, what is this? See no evil, talk no evil. I saw the other time. See no evil, talk no evil, or something.
Again,
The previous slide. The previous slide. The slide before this. Yes. Speak no evil, see no evil, and hear no evil. What
no,
does that
it's like helping you to memorize.
Okay.
Okay, it's not important. Okay, just to memorize the shape. Okay, and here, guys, if you want to be familiar with X-rays, just write in the Google low forte fracture type 1. They will give you many images. Low forte type 2, low forte type 3, and you have to be familiar with that. Okay, for example, temporomandibular joint dislocation X-ray. They will give you all dislocation. Because the exam, they are giving images, common images from Google. Okay, so this is how to study and how to be strong in images, strong in X-rays. This one, what is the diagnosis?
It is the third level.
LS type 2. fracture.
L is type
Type
3.
Type 3, type 3,
Type
type 3.
It is
Excellent.
involving both the.
Yeah, so the teeth, three types,
Top.
three layers: enamel, dentin, and pulp. Okay, 1, 2, and 3. So here L is fracture type 3. Why type 3? Because fracture of 3 layers: enamel, dentin, and pulp. And here the blood coming from the pulp. Okay, so source of bleeding from exposed blood. They can ask you directly, where is the site of bleeding? So which layer? Pulp. Complication, they can give you options and you can choose. For example, you can choose pulp necrosis or pulpitis, maybe total dental loss. Okay, chest injuries, this is normal. Anything other than that, it's abnormal. So you have to check the chest wall, compare the right and the left. Okay, and here also the border of the lung, the radiolucency of the lung, the border of diaphragm, okay, and ribs, okay, and the mediastinum. So here, any major trauma to the chest, you have to be familiar with 6 killers, and you have to be familiar with life-threatening injuries. 6 killers like airway obstruction, we discussed already, tension pneumothorax in B, breathing, open pneumothorax in B, breathing, massive pneumothorax in B, breathing, and the flail chest in breathing. Cardiac tamponade you can consider in B or in C, no worries. But ideally, it's in C, circulation. So atom FC. Life-threatening injuries in secondary survey. Primary survey, it means you will check airway, breathing, circulation, disability, exposure. So it's called primary survey. Secondary survey, after you finish primary survey, you will check for any life-threatening injuries like simple pneumothorax, pulmonary contusion, trachobronchial tree, blunt cardiac injury, traumatic aortic dissection, traumatic diaphragmatic injury, blunt esophageal rupture. So here in any breathing, you have to be familiar with the treatment. Tension pneumothorax, needle decompression followed by chest tube. Massive pneumothorax, chest tube, and the restoration of blood volume, so you can give IV fluid and the blood transfusion. Also, regarding cardiac tamponade, so precardiosynthesis. As we said before, it will be thoracotomy if arrest, but if not arrest, so you can do precardiosynthesis. Flail chest, lung confusion, so chest tube, intubation, ventilation. If the patient maintaining breathing, so his oxygen saturation normal, so no need for chest tube. Diaphragmatic injury, so you can intubate without bagging. So you can intubate and connect to oxygen without back valve mask. Okay. Anyone has any question? Dr. Osman, you raised your hand. You need anything? Okay. So here, how to interpret chest X-ray? So you will ask yourself, what is the site and the site of the lesion? Is it left or right? Opacity. So if you find opacity, maybe lung contusion or pneumothorax, jet black air, vertical visceral line, collapsed lung or absent, bronchovascular marking. So if like that, you can think about pneumothorax, chest wall deformity, multiple rib fracture, flat chest, shifting of trachea and or mediastinum. So think about tension pneumothorax or massive pneumothorax. Also wide mediastinum. So think about aortic injury. Here also, whatever traumatic or non-traumatic, if you find wide mediastinum, think about aorta. If non-traumatic, think about aortic dissection. If traumatic, think about aortic injury. Subcutaneous emphysema, it will be lateral to chest wall or in the neck. Absent hemidiaphragm, so it's a diaphragmatic injury. So here, who want to interpret this X-ray?
Tension left
Tension
thorax.
left tension pneumothorax.
Tension pneumothorax.
Excellent. So first of all, check the chest wall. The chest wall here, the left side and the right side. So same, okay? The chest wall here, same the chest wall here. So it's a normal. Here, I can see the problem in the left side, okay? Whatever, I can see something abnormal, okay? So first of all, check the chest wall. After that, check opacity. I cannot find opacity. I can see jet black air. It's dark here than here, okay? This is the normal. So if dark and the lung borders here, okay, and then no bronchovascular marking here. Here I can see bronchovascular marking. Here also bronchovascular marking until here, because this is the borders of the lung. So this pneumothorax. And here I can see the heart is deviated and the trachea is deviated. Okay.
Shifted mediastinum.
Yeah. So here, how to understand it's deviated or shifted? You can check the distance between chest wall and the heart, and the chest wall and the heart. Can you see the difference? It's very obvious. Okay. So here it's a tension pneumothorax. I can understand tension pneumothorax from the chest X-ray itself. How to confirm? By vital sign. The patient will be unconscious, or maybe hypotension, or maybe collapse or arrest. Okay. What is the treatment here, guys?
Needle
Urgent
decompression.
needle
Needle
decompression.
decompression.
Followed by
Chest tube.
Chest tube.
Chest tube
Insertion.
Insertion.
So if you find the option in the exam, needle decompression, choose. If you find the option needle decompression followed by chest tube, choose this one. Okay, and so on. Okay, what is the diagnosis here?
Left tension pneumothorax. Left tension pneumothorax.
Left-sided tension pneumothorax
subcutaneous
with
emphysema.
Okay.
There is multiple fractures as well. We can see
And split chest.
In
five,
4,
5, 6, 7.
5, 6,
Yeah,
7 ribs.
excellent.
Yeah.
Okay.
Flail chest also on the right side.
Yeah. Okay. So here I can see, first of all, the lesion in the left side. I can see something abnormal here in the left side. Okay. I can compare quickly between the left and the right. And here I can see black color. Here it's normal, no black color. So it's called surgical emphysema or subcutaneous emphysema. Okay. In the neck and in the axilla. And here is a wound here. It's very obvious in the subcutaneous tissue. Okay. And here I can see fracture in this rib, in this rib, in this rib. Okay. And in this rib. So it's a flail chest. And here also the mediastinum slightly deviated. Okay. And here's the border of the lung. Okay. This is the border of the lung. So it's a tension pneumothorax. It's a subcutaneous emphysema. It's also
Chest.
yeah, flail chest. So what is the treatment?
For pneumothorax, it is going to be,
Chest tube.
but chest tube would be the better. Intubation with chest tube.
Okay, chest tube. And what about the pain? The patient has severe pain.
Analgesic.
Analgesic.
Intercostal block.
Intercostal block, excellent. So you can give IV morphine after the patient be stable. You have to confirm the patient stability. And you can do intercostal nerve block, excellent. If the patient doesn't have tension pneumothorax, do you think he needs chest tube?
No.
No need, okay? If he has tension pneumothorax, so you can insert needle thoracocentesis followed by chest tube. What do you think, guys?
Massive hemothorax on
It is
the left.
left-sided massive hemothorax.
Left-sided massive pneumothorax.
So
Left side.
first of all, which is the normal, which is the abnormal?
Right,
Right
side is normal. and
Right side is
Side
normal.
abnormal.
Left side is abnormal.
Okay. So here is the abnormality because absent of lung. Okay, it's there, but it's obscured by fluid, by blood. Okay, so here, what about chest wall? Same.
Chest wall normal.
Same, normal. Okay, and what about opacity?
Homogeneous opacity on the left.
Yeah, if you find the complete opacity for the hemothorax, left hemothorax, so it's a massive hemothorax. But if you find a small opacity, so it's a hemothorax, simple hemothorax. Okay, and here, what is the treatment?
Surgical chest drain insertion.
Just chest tube insertion with corresponding blood transfusion.
Restoration of blood volume. Restoration of blood volume. So if you find this option in the exam, you can choose. Okay. Means IV fluid and the blood transfusion. Okay. So if you find open pneumothorax, it means sucking wound. The patient has penetrating wound and he has sucking wound. And whatever the patient has complication or not, so you will do 3-sided sterile occlusive dressing. What is the definitive management?
Chest tube insertion.
Chest tube insertion. Because maybe after 1 minute or maybe after a while, the patient will go to tension pneumothorax.
Tension pneumothorax.
What is the diagnosis?
Right-sided
Right
subcutaneous emphysema and
right lung contusion with subcutaneous emphysema.
yes.
Okay, excellent. So here, the chest wall here, it's normal. Can you see the chest wall here? It's a deformity.
There are some rib fractures as well. Yeah.
Yeah.
Yes.
Here, it's not obvious regarding the fracture, but here you can compare the chest wall with the chest wall. So here it's a flat chest. Okay, and here also subcutaneous emphysema. Can you see here it's a clear, here it's a black. Okay, and here opacity. Here it's a complete opacity or some opacities?
No, some opacity.
Some opacity.
Can you see the difference between this one and this one?
Yes.
Okay, so it's called the lung contusions.
Yes.
Lung contusion, it means like lung injuries with bleeding, some bleeding, okay, inside. That's why you can see some opacities, okay? So here, what is the treatment?
Chest tube and intubation.
Excellent, chest tube and intubation, because the bleeding here will increase, okay? What is the treatment?
It is chest tube and intubation. It is flail chest.
Yeah. Already the patient
on the right
chest, and then
already the patient has two
chest tube insertion already in.
upper and lower.
Yes.
And the patient intubated already.
Yes.
Okay. What about this? This is the normal or this is the normal? Left or right?
The right is abnormal, the left is normal.
Left is normal.
Yeah. So it's an opacity, complete opacity or some opacities?
Complete.
It is complete opacity.
So it's a massive hemothorax, okay?
Yes.
What is the next investigation?
Thorax.
You will do, I will give you two options. You will do E-fast or CT scan.
CT scan.
E-fast.
CT scan.
You have to ask me, the patient is stable or not.
E-fast is patient stable.
You have to ask me. So you have to check the scenario, okay? When you read the scenario in the exam, read the last sentence in the scenario and check the options. If he said, for example, the next step, you have two options, for example, E-fast or CT scan, go back to the scenario and check the patient is stable or not, okay? So regarding this patient, if I find he's stable, E-fast. If I find the patient is not So sorry, if unstable, E fast. If the patient is stable, CT scan.
CT check.
Yeah. So the most important in chest injuries, tension pneumothorax and massive pneumothorax. Okay. How to differentiate between them, guys?
Percussion.
Intense.
Percussion, excellent. Percussion.
Yes.
Okay. Okay. So we discussed already regarding this thing. The most important, how to understand its tension pneumothorax. So you will find respiratory distress and instability, tracheal deviation to the other side, unilateral absence of breath sounds in the side, hyperresonant percussion, distinct neck veins, cyanosis. Okay. Okay, if the patient has penetrating wound in the fifth intercostal space, so you will insert chest tube where?
In the safe triangle.
Yeah, where? He has
The fourth
In the
intercostal space anterior to the
fourth
mid-axillary line.
mid-axillary line.
Excellent. So if the patient has wound in the fifth intercostal space, you will insert in the fourth intercostal space. If the patient pregnant, you will insert where?
In third
In third
intercostal
space.
space, anterior.
Fourth intercostal space as well. Okay,
Oh.
fourth intercostal space. Okay, because she has uterus with baby, so the diaphragm will be elevated. Okay, so massive pneumothorax will be decrease the chest expansion, decrease the breath sound, dullness to percussion. So how to differentiate? As we said, percussion. Traumatic aortic rupture. Traumatic aortic rupture, it's in primary survey or secondary survey?
Secondary.
It is secondary survey.
Secondary survey. Okay. So you will find widened mediastinum, has the left lung field, obliteration of aortic node, fracture of one or two ribs. So if you find in the scenario the patient has fracture one or two ribs, you think about traumatic aortic disruption or transection or rupture. Okay. Also, in your practice in real life, any patient with fracture in the first and second rib, you have to consider that. Presence of pleural cap, elevation of rightward shift, right mediastinum bronchus, depression of left mediastinum bronchus. So you have to be familiar with these features. Maybe they will give you options in the exam, so you can choose. Okay, deviation of esophagus. If you are inserting a nasogastric tube, maybe it's deviated to the right. So this one, it can be ruptured like that, but with aneurysm, sometimes like that, sometimes like that. And this is the X-ray. Okay, and this one also, wide mediastinum. So it can be wide mediastinum or pleural cap. Okay, so what is the investigation, guys?
CT scan.
of the chest.
CT scan. Okay. Regarding the abdomen, the most important abdomen, you have to check the scenario. Is it blunt or penetrating? If blunt, you think about what?
Screening rupture.
Spleen.
Splenic rupture.
Yeah. If penetrating,
Liver.
liver. Excellent. Okay. So here, if blunt abdominal injury, the most common spleen. If penetrating abdominal injury and the stab wound, so think about liver. If penetrating but gunshot wounds, so think about small bowel. He went to do laparotomy in penetrating. He went to do laparotomy in blunt. So you have to be familiar with the indication because it can be an option in the exam. So in penetrating, the patient has hypotension, go directly for laparotomy. The patient has evisceration, go directly for laparotomy. The patient has bleeding from any orifice like mouth, urethra, or rectum, so laparotomy. Gunshot with trajectory tracks, so go for laparotomy. What if the patient has blunted trauma, abdomen trauma? So hypotension and the positive fast. So can we do fast and penetrating, guys?
No.
No need for fast and
No.
because it's not indication, okay? But if the patient has blunted trauma and he has hypotension, so you can go for fast. If the patient has peritonitis, air under diaphragm, visceral injury, if you do CT scan. So the management in any circulation, in general, in any resuscitation, IV access, bloods, as we said, hematology, biochemistry, blood gas, blood culture, toxicology screen, GSS, and cross match. Okay, and of course you will do ECG, chest X-ray. Medication here, you will give IV fluid up to 1 liter, blood transfusion, 2 units O negative blood, and cross match 4 units or 6 units. Of course, analgesia after stabilization of the patient. Tranexamic acid. If the patient has penetrating injury, you will give prophylactic antibiotic and tetanus immunization. Okay, 4 causes of shock in fast. So we have 4 views in fast. So upper quadrant, right upper quadrant, left upper quadrant, and also pelvic view and pericardial view. So you have bleeding from liver, as we said in penetrating, bleeding from spleen, as we said in blunt, cardiac tamponade in pericardial view, bleeding from pelvic vessels in general. Did I mention here, guys, bowel?
No.
Did I mention kidney?
No.
No.
So it's not a cause of shock. Okay, so we are using fast to check liver, spleen, heart, and the pelvis. Okay. Okay. What is the diagnosis here?
There's an air under the
Air under the right semi-diaphragm.
I would say penetrating mode.
Air under the. So this one, it's normal. This gas in the stomach. But this one, air under the. So this one, if blunt trauma, what is the definitive treatment?
Laparotomy.
Laparotomy.
That brought me.
Yeah, excellent. Laparotomy. Okay. What is the diagnosis?
Pelvic
Open book.
fracture.
Pelvic fracture, open book.
Open book fracture or pelvic fracture. Okay. So what is the treatment?
Pelvic binder.
Pelvic binder.
Pelvic binder, and also you can tie the lower limbs and do internal rotation. Okay. If you don't find pelvic binder, what will you do?
You tie the 2 lower limbs together and internally rotate.
Excellent. And the bed sheet. Okay. Okay. What is the definitive treatment? Vessel embolization.
Surgery.
Vessel embolization. Whatever surgery or angiography, it depends. Okay. So here regarding fast. Okay. So we have 4 views as we discussed. So right upper quadrant. So this one subxiphoid transverse view for heart. Okay. And longitudinal view for right upper quadrant, left upper quadrant, and suprapubic region. Extended fast. So we are using for pneumothorax or hemothorax. A fast. So these are the views. 4 views. So we are checking the heart, liver, spleen, and pelvic. Subxiphoid view, echocardiogram, like that. Right upper quadrant. So you can see the liver, you can see the kidney, and here, this should be like that, the border line between liver and the kidney without fluids. Okay, so this is the liver, this is the kidney. Is this normal or abnormal?
It's normal.
It is normal.
Okay, so if you find the border like that, it's normal. But if you find the fluid here, I cannot see fluid. Here also kidney. Okay, so the membrane always shiny like that, very white. So it's normal. This one left upper quadrant. So the kidney, the spleen, the space between the kidney and the spleen. Can you see the membrane shiny? It's normal. Okay. Spleen, kidney, normal. The bladder because of fluid, urine in the bladder, it's black, normal. Can you see any fluid here?
No.
No.
Okay, so it's normal. This one, it's for EFAST, for pneumothorax or pneumothorax. It will be in the upper part, here or here. Okay. So this rib 3, rib 2, and the pleural line, shiny. Okay, which one is normal, guys? This one or this one?
The pleural side is the normal one, where you can.
Okay.
Irregular pattern, barcode pattern.
Okay, this slide is normal. This slide is normal. So if you find barcode, can you see barcode? It's like barcode.
Yes.
This one from here up to here, barcode. But this one irregular pattern, it's a different. Okay, so this normal. But if you find like this another slide. So here
This is abnormal.
Yeah,
Abnormal.
this barcode and here barcode. So if you find the barcode all over the lung, so it's a pneumothorax. Okay.
Yes.
Can you see the difference? This barcode, but this irregular pattern. The other slide, all barcode. So it's abnormal. Okay. So again here, can you see all barcodes?
Yes, sir.
Yeah. So it's this one abnormal. This one
Is normal.
Normal.
okay.
The sure sign.
Yeah. This liver and this kidney. Can you see the space?
Yes, sir. Fluid.
Fluid.
Hepatorenal resus.
Yeah. So here it's a positive fast. Right upper quadrant or left upper quadrant? This one.
No,
Right
it is right upper quadrant.
Right upper
Because
quadrant.
of liver. Okay. This one. Free fluid.
It is left upper quadrant in between
Can you see the
spleen.
diaphragm? It's very shiny.
Yes.
And the left kidney. So fluid between spleen, kidney, and the diaphragm. This
Yes.
left or right upper quadrant?
Left upper quadrant.
Okay. Bladder and here fluid.
Yeah.
So which view?
Pelvic view.
Pelvic view.
Okay. What is the diagnosis?
In Morrison pouch.
Cardiac tamponade.
No, it is cardiac tamponade. True, true.
Cardiac tamponade.
Yeah. Can you see the fluid here? This is the heart.
Yes.
Can you see the ventricle is collapse here? Okay.
Yes.
Ventricle, atrium,
Yeah.
ventricle, and the atrium here. Okay. Here regarding the fluid loss or hemorrhagic shock, the most important, guys, to understand the blood loss, the blood pressure. So if you find the blood pressure, systolic blood pressure decreased, which grade?
Grade 3 and 4.
So first of all, blood pressure. If you find the blood pressure decreased, okay, so it's a class 3. Okay. Clear?
Yes, sir.
Yeah.
And also in class 4.
Yeah, I mean, if decreased, start from class 3.
Okay.
Means class 3 or more. Okay. So the patient lost more than
1,500 to
1.5
2,000.
liters.
yeah. Okay. So he lost more than 1,500 ml, or he lost more than 30%. Okay. Okay. Major trauma spine. So what is your concern as a physician, emergency physician? So here, cervical, thoracic, and lumbosacral. So what is your concern, guys?
Neurogenic shock.
Cord injury.
Spinal cord injury. Spinal cord injury. Okay. So in cervical, think about syndromes. So think about central cord syndrome, think about anterior cord syndrome, posterior cord syndrome, and Brown-Séquard syndrome. You have to be familiar with 4 types. They can ask you in the exam. Okay. So features, they can ask you about the feature, or the opposite. They can give you the feature and ask you what is the most likely syndrome. Okay. Okay. And here we finished cervical. What about thoracic? So thoracic here, think about neurogenic shock or what?
Spinal shock.
Spinal shock. Excellent. Regarding lumbosacral, what is your concern? Spinal cord injury, what is your concern here?
Cauda equina.
Cauda equina syndrome.
Excellent. So if you find, I want you to be very intelligent, guys, when you are studying and when you are in the exam. So if you are studying for cervical, they can give you the patient, for example, he has fracture in C4, for example, or C1 or C2. So think about syndromes like central cord syndrome. He will ask you about that. If he give you fracture T1, think about, most likely he will ask you about neurogenic shock or spinal shock. If he give you lumbar 1 fracture, so expect he will ask you about Cauda equina syndrome. This is how to study. This is how to prepare yourself. This is how to get high score. Okay. Here you have to check the alignment, 3 lines. Okay. So this cervical 1, cervical 2, 3, 4, 5, 6, 7. Okay. Cervical 2, you have dense inside. It should be inside C1. So C1 like ring. And the C2, there is dense here. There is dense, this dense inside C1. So the most likely in the exam, C2 fracture, dense fracture. Okay. So this is the dense C2 and this lateral border of C1. Okay. You have to find normal alignment here. Okay. And the distance here should be same distance here, but here it's not the same. If you find not the same and here normal alignment, it means it's normal. It means the patient not centered. So here the distance it's very wide, but the alignment here normal. Okay. So the patient is normal. Okay. But he is not centered. It means he is rotated. Okay. What about alignment here, guys? Any alignment here or abnormal? Abnormal. Okay.
Is abnormal.
Yeah. So here there is no alignment. Alignment, it means this border should be here. it means there is fracture in C1. This lateral border of C1. And here widened. Can you see? It's very wide. Okay. Can you see the difference? This is the normal. And here very wide. Why? Because fracture of the ring C1. That's why the lateral border widened. And this is a big or dense. It's called the big or dense or odontoid. 3 names. Big or dense or odontoid process of C2. This one normal alignment. Okay. This one fracture of the dense of big view. Okay. Of the big of the C2. Okay. So can you see, guys? Obvious?
Yes.
Yeah. This one fracture of big here. So this view, it's called odontoid big fracture open mouth view. Okay. So you ask the patient to open his mouth and take X-ray. This is another fracture for C2. So you have in C2 2 fracture, dense or fracture of the vertebra itself. And this is one unlikely to be in the exam because the patient most likely died, hangman fracture. Okay. So if you find horizontal fracture, horizontal like that, okay, so it's called the dense fracture. But if you find vertical fracture in C2 like this, okay, so it's called hangman fracture. What is the diagnosis here, guys?
This.
Can you see the alignment?
Yes.
It's a disruption here. Disruption here. Okay. So this horizontal fracture or vertical fracture?
Horizontal fracture.
So it's a dense fracture. Okay. This part should be here. Should be here. Okay. So it's a dense fracture of C2. This one, it's clear. Okay. So can you see this border?
Yes, C2
Not
peg
matching
fracture.
with this border. Okay. So this anterior displacement of the dens. Okay. What is the fracture here?
Wedge fracture of L1.
Yeah, excellent. To count from down. So this is sacrum, lumbar 5, 4, 3, 2, 1. Can you see the height? The height here, almost the same, almost the same, almost the same. But here, can you see the height?
Yes, it's reduced.
Yeah, compressed. So this is the posterior side. This is the anterior side. So it's called anterior compression of lumbar 1. So what is your concern here, guys?
Cauda equina.
Equina syndrome. Excellent. Okay. Okay. Burn. So burn here you have in airway. What is your concern in airway?
Laryngeal edema obstruction.
Yeah. So inhalational injury and airway obstruction. So what is your immediate action here regarding airway?
Early intubation.
Early intubation.
Excellent. Early intubation. Regarding breathing, we finished the airway. We will go to breathing. What is your concern here? Circumferential burn. Okay. So the patient has massive burn in the anterior chest and in the posterior chest. So you have concern for circumferential burn. It means the patient cannot breathe. The patient has restriction for chest rise. Restriction for chest rise. So what is the treatment?
Sclerotomy.
Sclerotomy, excellent. Okay. And in circulation, what is your concern?
Hypovolemia.
Hypovolemia.
Hypovolemia or shock. Okay. So what is your treatment?
IV fluid.
Parkland.
Okay, so you will give Parkland formula according to body surface area. So you can
Width
give,
and
yeah, you can give 2 to 4 ml per kilogram per body surface area. Okay, so here also inhalational injury. Here you can see eyebrow and the eyelashes, so singeing, and here also, and the facial burn. So all these indication for inhalational injury. Okay, and this patient has indication of early intubation. Okay, even the patient is awake, even the patient is conscious, but this patient needs early intubation. Okay, at any time his airway will be obstructed. Okay, respiratory failure, presentation number 5. So we are talking about pH should be, this is the normal range, 35 up to 45, PO2 11 to 14, and BCO2 4.5 to 6, and basic cis -2 to +2. Bicarbonate 24 up to 30, lactate should be less than 2. Any other reading, so it's abnormal. Respiratory failure, here we have 2 types, type 1 and type 2. So type 1, it's called hypoxic respiratory failure. Type 2, hypercapnic respiratory failure. It means if you find the BO2 less than 11, it's respiratory failure. If you find BaCO2 high, it's respiratory failure type 2. If not, it's respiratory failure type 1. Again, respiratory failure, it means BO2 less than 11. If you find BaCO2 high, it's type 2. If not, it's a type 1. Okay. So type 1 here may be pneumonia, pulmonary edema, ARDS. Type 2, it means the patient deteriorated. So here, carbon dioxide retention. Okay, maybe blockage or narrowing of the airways, weakness of muscles. Okay, maybe overdose of opioids. So here, of course, look, listen, and feel for respiratory rate, depth of respiration, chest movement or rise, accessory muscle, color, oxygen saturation, and listen, okay, for his words, is oriented or confused, added sounds or not, like wheezes, crackles, broken breathing, feel, chest expansion, symmetrical movement, tracheal deviation also. So signs of respiratory failure, the patient has cyanosis, shortness of breath, accessory muscle, added breathing sounds, restlessness, anxiety, new confusion, reduced oxygen saturation, tachycardia, arrhythmia. How to treat? Of course, you will give oxygen. Also, you will use non-invasive ventilation, and also you can use intubation if needed. And it treats the underlying cause. So non-invasive ventilation, you can use CPAP or BiPAP. CPAP here for type 1 respiratory failure. We will talk about ventilation in details in its chapter. So CPAP for type 1, like pulmonary edema, BiPAP for type 2 respiratory failure, COPD patient. Invasive ventilation in case of ARDS or obese may be raised intracranial pressure or head injury. So this non-invasive ventilation should be the patient conscious, cooperative, and not in stress, not agitated, no vomiting, and so on. This invasive, if the patient cannot tolerate non-invasive. And this is a machine of ventilator. So you can start the normal RR, as you know, 12 to 20. The normal respiratory rate for any patient should be 12 to 20. That's why you have to start the respiratory rate was 12. Okay, and titrate. If in the exam, if they give you 12, so you can start by 14. If they give you 14, you can start by 16. If they give you 16, you can start by 18, and so on. Okay. So you have to be familiar with modes: IBBV, SIMV mode, BCV, BiPAP, BS, or ASP. Here, the most important to understand which one is volume controlled or pressure controlled. Okay. Also, the advantage. The most important here is SIMV mode. Okay. It will be volume controlled or pressure controlled. So it's spontaneous or controlled. Okay. And synchronized. This is the most important mode you can choose in most patients. Okay, so what is the meaning of SIMV mode? Synchronized intermittent mandatory ventilation. So can be volume or pressure control, is a controlled mode of ventilation, doesn't require any spontaneous respiratory effort from the patient, and is synchronized. Synchronized, it means the patient will take breath, the ventilation machine will give breath. If the patient is not taking breath, it will not give. So it's synchronized with the patient. Asthma. So if the patient has asthma, you will treat as a normal algorithm. You will give nebulization. And if the patient is not responding and needs intubation, so you have to understand the indications: severe hypoxia, altered mental status, failure to respond to medication, and the non-invasive ventilation, respiratory or cardiac arrest. So you have to use which anesthetic medication, guys?
Ketamine.
Ketamine.
Ketamine, okay. So ketamine, 1 to 2 milligram per kilogram. Here, propofol, it's not preferred because the risk of hypotension. So ketamine, you can use subdissociative dose, 0.1 milligram per kilogram, followed by IV infusion. Also, you can use rocuronium or succinylmethonium as paralytic agents. Okay. So lung protective strategy, as we said, you can start a respiratory rate 6 to 8 breaths per minute, tidal volume 6 ml per kilogram, and permissive hypercapnia. As we said, you have to be familiar with the normal blood gases. Okay. So here, ARDS, whatever pneumonia or sepsis, may be bacteria, fungus, or virus. Okay. The diagnosis of ARDS, it's acute onset within 1 week. Bilateral opacities on chest X-ray, PaO2 ratio for FiO2, it will be less than or equal 300 on positive index respiratory pressure. Okay, so these are the criteria to diagnose ARDS. So they will give you scenario for within 1 week, and also regarding bilateral opacities, they will give you chest X-ray, and if mentioned PaO2 FiO2 ratio less than 300, so you can diagnose ARDS. Severity, so mild, moderate, severe. If the ratio 200, so mild, 100, moderate, less than 100, so it's a severe. And it should be not fully explained by heart failure or fluid overload. So like that. So bilateral opacities and within 1 week, so it's ARDS. Investigation, like any respiratory, so ABG, chest X-ray, BNP, echocardiogram, blood sputum, urine culture to investigate for the presence of sepsis. Management of ARDS, so it will be supportive care and also the patient in prone position, you will give IV fluids, antimicrobial, antifungal, antiviral. It depends on the blood culture. And lung protective strategy. As we said before, lung protective strategy, low respiratory rate, low tidal volume, beep 5 to 15, permissive hypercapnia. Regarding sepsis, you have to be familiar with 6 criteria. Okay, so temperature more than 38 or less than 36, heart rate greater than 90, RR greater than 20, confusion, new onset confusion or drowsiness, white blood cell more than 12 or less than 4, blood sugar greater than 7.7. So we are talking about SARS. SARS here, you have to find 2 or more criteria of these criteria. Okay. They are using also SOFA criteria. So it's 3 criteria only: systolic blood pressure less than 100, respiratory rate more than 20, GSS less than 40. Okay, so any of them, GSS, RR, blood pressure. So if you find here 2 or more, here 2 or more, you can use any of them. Regarding SARS, we discussed already. So sepsis here, it means SARS plus suspected or confirmed infection. It means, for example, UTI or pneumonia or anything. So we are calling sepsis. If you find the sepsis and any sign of end-organ damage, for example, the patient has liver function impaired or kidney function impaired, so it's a severe sepsis. Or maybe hypotension, or maybe lactate more than 4, so it's a severe sepsis. Septic shock, it means persistent. It means you give fluid and still persistent. It's called septic shock. Differential diagnosis may be pulmonary embolism, the cause of sepsis, maybe acute myocardial infarction, maybe heart failure, acute delirium, pancreatitis, diabetic ketoacidosis, adrenal insufficiency, acute blood loss and hypovolemia, trauma, tissue injury, burns, drug reaction, including neuroleptic malignant syndrome, intoxication and poison, including carbon monoxide poisoning. So risk factors, extremes of ages, the patient is very young or very old, people who are very frail, immunocompromised, immunosuppressed, trauma. So all these patients, they are very easy to get sepsis. People with any breach of skin, people who misuse intravenous drugs or alcohol, people with indwelling glands like custard, pregnant, postpartum. Okay, so also neutropenic sepsis, it will be in patients who are immunosuppressed taking chemotherapy. So neutropenic sepsis here, temperature more than 38 and the neutrophilic count less than 0.5. So here you have to use tazocine, or it's called piperacillin and tazobactam. It will be 4.5 grams. So sepsis, as we said, 3 out and 3 in. Blood culture, lactate, urine output, and 3 in, you have to give IV antibiotic after blood culture, and IV fluid and oxygen. So here, the hand is swelling, and if he has features of sepsis, so it's a cellulitis. So here, hand infection, cellulitis class 3, signs of marked systemic illness. So here, complication, maybe the patient will get compartment syndrome, acute limb ischemia, necrotizing fasciitis, also multiple organ failure, so local or systemic. Treatment, as we said, sepsis 6, so 3 in and 3 out. What is the diagnosis, guys, here?
Meningococcal septicemia.
Okay.
Meningococcal septicemia.
Yeah, if the patient has this image and you have to check the scenario. I cannot say meningococcal septicemia until I found the features of sepsis in the scenario. Maybe this Henneschenlein Berbera. Okay, so if the patient has, for example, normal vital signs and he has recent flu symptoms and he doesn't have any abnormality, so maybe Henneschenlein Berbera. But if he has, for example, blood pressure is low and CRT is high, and he has fever, and he has tachycardia, now I can say meningococcal septicemia. So diagnose meningococcal septicemia and the treatment 3 in and 3 out, as we said. Here, specific treatment 2 grams ceftriaxone IV and dexamethasone 8 milligram. Investigation, as we said, 3 in, 3 out. Blood culture, gases. Shock. So presentation number 7, we are talking about shock. You have many types of shock, maybe cardiogenic, obstructive, tension pneumothorax, cardiac tamponade, pulmonary embolism. So here's the problem in pump failure. Distributive shock, the patient has poor vessel function, like septic shock, neurogenic shock, anaphylactic shock, psychogenic shock. Maybe he has hypovolemic shock, like low fluid volume. For example, hemorrhagic shock. Hemorrhagic here, maybe it's traumatic or maybe non-traumatic, like for example, massive GI bleed, okay? Non-hemorrhagic shock, like gastroenteritis. So hemorrhagic or non-hemorrhagic. So the management in any shock, whatever the cause, fluid challenge, so you can give 250 up to 500 cc normal saline over 10 to 15 minutes and treat the underlying cause. After that, reassess after 15 minutes. So you have methods of reassessment. Non-invasive, you will check blood pressure after 15 minutes. Urine output should be 0.5 ml per kilogram per hour. Resolution of end organ malperfusion. For example, the patient before fluid, he has a heart rate 170. After fluid, his heart rate 120. So he is improving. Non-invasive bedside test. So you can use ultrasound to check inferior vena cava. If inferior vena cava is tinted, no need to give more fluid. If the inferior vena cava collapse, you can still give fluid. Unconsciousness. Unconsciousness here, you have many causes. Maybe something related to the brain, to the chest, to the airway, to the chest, to the circulation. So whatever, maybe overdose and so on. Anyway, the cause of unconsciousness, you can say shock, asphyxia, like foreign body fluid, poisoning, like gas inhaled or ingested, head injury, stroke, epilepsy, fits or seizures, hypothermia or hyperthermia, diabetes, heart attack. So bedside test, whatever the cause, first of all, blood sugar, ECG, ABG, chest X-ray. So bedside tests for any unwell patient. Urine dipstick, beta HCG if female, pulse oximeter. The management here, you have to follow ALS guidelines, so airway, breathing, circulation, disability, and they treat the underlying cause. Shocking. So shocking here, you have to be familiar with the algorithm. So general signs of shocking, witness the episode, coughing or shocking, sudden onset, how to understand it's shocking. So someone told you, witness. The patient presented to emergency room coughing or shocking. Sudden onset, he said he was 10 minutes ago, he was good. Attack occurs while eating, he was eating. Patient may clutch neck. So if the patient has ineffective coughing, how to understand? He is unable to vocalize, quiet or silent cough, unable to breathe, he has cyanosis, decrease the level of consciousness. How to understand its effective coughing? So crying or verbal response to questions, loud cough, able to take a breath before coughing, fully responsive. So this feature can be present in the exam, so you have to be familiar with that. Mild airway obstruction in choking. How to understand he has airway obstruction, mild or severe? If the patient is able to speak, mild, able to cough, breathe, respond, so it's mild. If not, so it's severe, unable to speak, attempt at coughing silent, unable to breathe, maybe unconscious. So what about the treatment? So here, shocking, assess severity. As we said, mild or severe, according to the symptom. So if the airway obstruction with effective cough, you will ask the patient, whatever his adult or pediatric, you will encourage cough. Continue to check for deterioration to ineffective cough or until obstruction. So at any time, the patient can cough, encourage cough. Even for 1 hour. Is he coughing? So continue coughing. If the patient has severe, so it means ineffective cough. So check, is conscious? If conscious, you will do 5 back blows, 5 back blows like that, okay? Followed by abdominal thrust. Abdominal thrust, more than 1 year, whatever, adult or child, more than 1 year, okay? If the patient unconscious, start CPR. Unconscious, he did not say unresponding, he said unconscious, okay? So you will start CPR like that, okay? What about pediatric? We said more than 2. Suspect foreign body, airway obstruction, shout for help. If the cough effective, so encourage cough as adult. If not effective, so call resuscitation team. Is the child conscious? If conscious, it depends, infant or child. If infant, as we said, you will do 5 back blows and then 5 chest thrust. So 5 back blows like that, okay, and 5 chest thrust, okay. So this one for infant, this one, 5 back blows and 5 chest thrust. If child, you will give 5 back blows, then 5 abdominal thrust. So anyway, the conclusion now, more than 1 year, whatever child or adult, you will do 5 back blows and 5 abdominal thrust. If infant, you will do 5 back blows and 5 chest thrust. If unconscious, open airway, try risk breathe, because here a child, the difference between child and adult, 5 risk breaths, and the continuous pediatric basic life support, CPR. Okay, as we said. Okay, stridor. The most important in stridor, you have croup and you have acute epiglottitis. The most important in the exam, acute epiglottitis and croup. So this one is inflammation, and you can see what is the sign here, guys?
Thumb sign.
Thumbprint sign.
Thumbprint sign, yeah.
Yeah, excellent. So the X-ray, and here in the regarding the causative organism, the most causative organism, it's Haemophilus influenza type B, but because of the vaccine, it's not caused anymore by this causative organism. So you have to choose this option, Streptococcus species, like Streptococcus pyogenes, Streptococcus pneumonia, and so on. Okay. Other causes like Staphylococcus aureus, Pseudomonas species, Moraxella catarrhalis, Mycobacterium tuberculosis. I care about Streptococcus species. Okay. After vaccine, because most people now, children, they are vaccinated. The typical clinical features. So the patient has fever, sore throat, odinophagia, so pain on swallowing, drooling, because difficult of swallowing, anterior neck tenderness, cervical lymphadenopathy. So diagnosis, fiber optic laryngoscopy. And don't do fiber optic laryngoscopy in ER. It should be in areas such as operating theaters, prepared for intubation or tracheostomy if upper airway obstruction occurs. So this is a definitive diagnosis, fiber optic laryngoscopy. If not available, you can do lateral neck X-ray. You can see some print sign. So the management here, conservative with IV or oral antibiotic. Intubation may be needed in some cases. Organ donation, you have to be familiar. I sent the PDF. I cannot explain everything in the session, guys. I can help you with PDF, for example, for organ donation, and I can help you with any PDF for anything, but I can give you just hints in these talks, okay? So in organ donation, you have to be familiar what will you do if you want to donate, okay? And which organs, which tissues, and also indications and contraindication. Who can register to donate, okay? So here, regarding donation, so this is a website for NHS. If someone want to donate, he can press on this one. If someone doesn't want to donate, he can press this one. After his death, if they find he has registration to not donate, they will not donate after his death. So you have option to donate and the option to not donate. You have to register. In UK, like that, everyone, he has to be clear. Okay, whatever, donate or not donate. So what can you donate? Types of organ donation: heart, lungs, liver, kidneys, pancreas, small bowel. We are talking about organs. And the tissue donation, so tissue, cornea, bone, okay? Who can become organ donor? So organ donation and eligibility. So anyone can register a decision to become organ donor after this. There is no age limit, okay? So all ages. To donate organs after this, person needs to die in hospital in specific circumstances. Who does it affect? So the opt-out system applies to everyone in England, except for those are part of what are called excluded groups. Excluded groups, like what? Under age of 18, we are talking about registration, not organ donation. So anyone who registered to donate or not to donate should be above 18. But if he died and his family presented, they can give consent for donation. People who lack the mental capacity to understand the new arrangement and take necessary action. Also visitors to England and those not living here voluntarily. People who have lived in England for less than 12 months before their death. Age limit. So as we said, any age. Can children join the NHS organ donor register? So parents and guardians can register their children, and the children can register themselves. So children who are under 12 in Scotland and under 18 in the rest of UK, at the time of registration, will require their parent or guardian agreement for donation to take place. So donation available for all, but registration to donate, it's available if above 12 in Scotland or above 18 in the rest of the UK with consent from the guardian or parents. Medical condition. So person cannot become an organ donor if they have suspected Jacob disease, it's a brain disease, Ebola virus disease, active cancer, HIV. So it can be an option in the exam, okay? Okay, Drew, So it's called the pro or alti. So it's the same, no worries. So here can be only used if there is no explanation for the event. The patient collapse and you don't find any other cause. So it's called pro. Duration less than 1 minute, typically 20 to 30 seconds. Sudden onset accompanied by return of baseline state. After that, you will be normal. Not explained by medical condition. So include one or more of the following: central cyanosis, how to diagnose, clinical, central cyanosis or pallor, absent decreased irregular breathing, marked change in tone, whatever hyper or hypotonia, altered level of consciousness. So high risk, when to say high risk, infants less than 2 months of age, history of prematurity, especially if less than 32 weeks, more than one event. Low risk if the patient age more than 60 days, born more than 32 weeks gestation. Differential diagnosis, you have to think about physiological, maybe gagging or laryngospasm or neonatal periodic breathing. Maybe heart problem, congenital heart disease, arrhythmia like prolonged QT. Maybe respiratory, the patient has foreign body, airway obstruction, laryngomalacia, congenital malformation. Maybe he has infection like pertussis, pneumonia, upper or lower respiratory tract infection, meningitis, encephalitis, septicemia. Maybe the problem in CNS, he has head injury, seizures, cerebral malformation, drug ingestion. Maybe GIT, gastroesophageal reflux, intussusception, testicular torsion. Maybe he has metabolic or toxin, like hypoglycemia, hypocalcemia, hypokalemia. How to do investigation? So if low risk, no need for investigation, and you can discharge the patient. If high risk, discuss with senior doctor, pedi consultant, or senior pediatric registrar. You can do routine laboratory and routine workup. Management of high risk. So discussion with ED consultant, consider admission for observation for 24 hours, cardiorespiratory monitoring, further investigation according to the presentation. Involve and refer relevant specialties as appropriate if underlying cause identified. Study protocol. So this from 0 to under 18 years. So you can use when the patient child under 18 and unexplained death. So you have to think about organ and tissue donation also. You can read this slide, guys, later. Okay. And also regarding general advice for all professionals when dealing with the family. Okay. So you have to inform the family. You have to also call the police, the coroner. Okay. So this is the flow chart. So here, if the child found collapse, so whatever inside the hospital or outside the hospital, it can be question in the exam. So if GP, health professional, first on scene, so you can call the ambulance, control center, inform police, ambulance crew here, attempt resuscitation, observation in the home, history, update police. Okay. If the patient inside the hospital, so A&E resuscitation team, call consultant pediatrician, A&E consultant, nominated senior doctor. So you have to follow this flow chart, and it can be a question in the exam. This flow chart very, very important. Okay. And the factors which may arouse concern. How to understand this child, this needs investigation or not. Okay. So certain factors like what? Previous safeguarding children, concern within the family. So he has previous record with social services, inappropriate delaying in seeking help, inconsistent explanation. They cannot give you explanation. Evidence of drug alcohol abuse in the family. Evidence of domestic abuse. So the husband hit the wife, any domestic abuse, so it can raise the concern. Evidence of parent carer having mental health problems, unexplained injury, presence of blood, neglect issues. So it's a very important. It can be an option in the exam. You have to read that. Okay, so you review a patient with airway obstruction in the resus room. Which of the following single least likely cause, guys?
Glasgow scale score of 9.
GCS score.
GCS score of 9.
Excellent. Which of the following statement regarding airway and breathing management in burn patient is true?
100 oxygen.
Option number 2.
The second one. The second one.
Okay, excellent. Which of the following not significant risk factor for airway obstruction with major burn?
Carboxyhemoglobin level of 6.
Yeah,
Excellent.
last one.
Which of the following is the most significant risk factor for airway obstruction with major burn?
Carboxyhemoglobin of
Option number 1.
The first one.
Excellent. Which of the following statement regarding airway and breathing management in burn patient is false?
High tidal volume. Should be
Option
used in anyway. First
Option number 1. sir.
One. We should use low tidal volume.
Low tidal volume, yes. Option 1.
Option number 1.